Welcome to Nobody Told Me. I'm Jan Black.
And I'm Laura Owens.
Did you know that depression is the leading cause of disability in the world? Clinical depression affects some 16 million adults in the United States and a growing number of children and teenagers.
If you or someone that you care about suffers from depression, you know it can be hard to treat. That's why there's been a lot of excitement about the promise shown by the drug ketamine in treating depression. And joining us on this episode is Dr. Gerard Sanacora, who is an internationally recognized expert in the use of ketamine in psychiatry. He's a professor of psychiatry at the Yale School of Medicine and also the director of the Yale Depression Research Program.
Doctor, thank you so much for joining us.
Thank you for inviting me.
We are all familiar with the word depression, but what is depression from a medical and psychiatric standpoint, so we all know what we're talking about?
Yes, depression is one of those complicated terms because it has a presence in our everyday language where we can talk about being depressed. But major depressive disorder or a major depressive episode is actually a serious medical condition, mainly categorized or mainly characterized by loss of interest, loss of ability to experience pleasure, but has other symptoms such as problems with appetite and sleep, and even the loss of the desire to continue living that really play a prominent role.
How is depression usually treated, and why is ketamine so promising?
So starting right about 50 years ago, a little bit more than 50 years ago, there was the development of what was called the monoaminergic hypothesis of depression, with this idea that there was a chemical imbalance in the brain, and specifically chemicals such as serotonin or norepinephrine were low in the brain, and this was leading in some ways to people feeling depressed. And for the past 50 years or so, the major method of therapy, or at least pharmacotherapy, medication therapy, has been these antidepressant-type drugs, originally drugs like amitriptyline and nortriptyline, which we call the tricyclic antidepressants, or the old monoamine oxidase inhibitors, the older medicines, but more recently the drugs like Prozac and Zoloft, the SSRIs, have always been used as the pharmacotherapy, along with talk therapies such as cognitive behavioral therapy.
And so tell us more about ketamine and how it differs from things that have been used in the past.
So ketamine is a very unique medication. Ketamine itself has been around since the late 1960s. It's had FDA approval since 1970 for use as an anesthetic agent. So ketamine was originally developed as an anesthetic. It's what's considered a dissociative anesthetic. It's used quite frequently in pediatric anesthesia. It's used in emergency rooms quite often. So we have a lot of experience with it, but not for depression. And now it's actually getting a little bit longer. It's been almost 20 years since some of these first studies were done looking at it for depression. But the idea of using ketamine to treat depression came out of a large basis of basic neuroscience research that suggested the glutamatergic neurotransmitter system could be directly involved in generating or causing depression, and that there were changes in neuroplasticity, actually the way the brain cells talk to each other. And the basic neuroscience research suggesting that ketamine may have marked effects on these systems and may do that very rapidly led to the early trials of trying ketamine back in the late 1990s that showed early evidence. But like most things in science, it took some time before it really gained momentum. And now there's widespread studies looking at the effectiveness of this treatment in treating people with severe depression.
So it's not a first-line treatment for people who are just getting diagnosed with depression as of right now, at least.
No, that's correct. As of right now, it's still premature to consider ketamine as a first-line treatment. Many of our standard treatments are actually quite effective for many people. Our standard treatments, including talk therapies like cognitive behavioral therapy, can actually be very effective for people and actually may have a better chance of keeping people in remission when they are successful. So there are other treatments that are a much better choice as a first-line treatment, including some of our standard medications like the SSRIs that have now been around for 30 years, and we know the long-term safety of these medicines. Ketamine, despite the fact that it's been around since the 1960s, 1970s, has almost always been used as a single dose or very infrequent intermittent doses because it was really being used as anesthesia. we really don't have all that much experience or data to tell us what the risk of repeated ketamine use is. In fact, we know that people that have overused ketamine or misused ketamine can actually suffer from some pretty severe problems, including some neurologic impairments and also problems with their urinary bladder. So we do know that it could be a dangerous drug if it's used too frequently or at doses that are too high.
When it is used for depression, how is it typically administered, and who are the kinds of potentially ideal candidates for it?
At first, I'll start by saying how it's typically administered. The early studies that were done were given with an IV dose administration. And interestingly enough, it wasn't because it was thought to be the most effective. It was back in the late 1990s, there were experiments using ketamine to actually generate a state of cognitive impairment. So researchers at Yale were actually looking at how ketamine may be a tool to help us understand psychosis and help us understand cognitive and perceptual impairment. And the dose they were actually using to study that and the route of administration, giving it IV over a 40-minute period, was the original way it was used in those early studies that showed that antidepressant-like effect. And that really has still been the primary way that it's been delivered, meaning giving it IV at 0.5 milligrams per kilogram over 40 minutes. Not that there was any great magic to that dose, at least that wasn't the way it was planned. You know, nobody said this is the right dose, this is the right way of giving it, this is the right duration to give it. There was a stroke of luck in there, but that still is the most common way to deliver the treatment, and that's where we have the greatest amount of evidence.
And who would be the ideal patient for that?
What we would consider really necessary is that you've tried standard antidepressant treatments, that you really have tried and have not had a good response to treatments like talk therapy, to treatments like some of the standard SSRIs or some of these other medications. So people that have failed at least 2 or 3 really good courses of other antidepressants would be sort of the minimum criteria that we would think of. But we also have to realize the severity of depression. So ketamine, one of the unique features is it does seem to have a very rapid onset of effect. So meaning for many people, there could be benefits as soon as 4 hours after taking it, which in certain situations could be extremely beneficial.
Right.
So for those people, it really has a great value. But what people sometimes fail to realize or recognize is that this, for most people, isn't curative. It isn't you take it, you feel better, and that's it. For the large majority of people, there will be some repeated dosing of ketamine required. And that's another very important criteria that we use, is that this is somebody that would be able to continue to receive the treatment. So we want to make sure that there are certain reasons why it wouldn't be a good idea, and we want to be very, very careful if there's people that have any tendency to have psychosis. It's something that we have to be very careful about, because there is some evidence that ketamine under certain situations may actually exacerbate these psychotic-like thoughts. So we have to be very careful with that. We also know that ketamine is a drug of abuse, that in some parts of the world, ketamine is a major drug of abuse. So we're very, very careful about starting this treatment in people that have a high risk for substance use disorders.
We're so glad you're part of our Nobody Told Me family of listeners. You know, the whole idea behind our podcast is to share information that you might not know about, that nobody told you.
Along those lines, we want to tell you about one of our sponsors, Native, the maker of a safe, simple, effective deodorant that works like none we've ever tried before. I've been using Native's coconut and vanilla deodorant, which is their most popular scent, and I can see why.
I've been using Native's lavender and rose scented deodorant, and I love it. Native comes in a wide variety of scents for men and women. They also have an unscented formula and a baking soda-free formula for those with sensitivities.
Native is made without aluminum, parabens, and talc. It has fewer, simpler ingredients than other deodorants, and while it costs a bit more, it's worth it. There's no risk to try it. Native offers free returns and exchanges in the U.S.
Subscribe and have Native conveniently delivered to your door every 1, 2, 3, or 4 months.
For 20% off your first purchase, visit nativedeodorant.com and use promo code NobodyToldMe during checkout.
Again, for 20% off your first purchase, visit nativedeodorant.com and use promo code NobodyToldMe during checkout. Is there any indication as to whether ketamine can be used in, and I'm sure that there is, in older patients as well as younger ones, or is it something that you tend to use in younger patients or tends to be maybe more effective in younger patients than older ones, and also the differences between men and women being treated with it?
So it still is very early, despite the fact that it has been out for over a decade and being used, but the amount of data that is actually generated and we have to really consider this that's been published is still relatively limited. There are certain things that we worry about. We know that at least at this dose, when ketamine is used, the dose that I mentioned, it can have significant effects on a patient's heart rate and blood pressure. So we want to make sure that the patient is healthy enough. And typically the increases that we see are about the equivalent of climbing up 2 flights of stairs, carrying a bag of groceries. So if a person is healthy enough to do that, for the most part, we can assume that they probably will be healthy enough, although there's variability in how big of an effect each person can have. But we do want to make sure that it's safe from that side. It also has a fairly pronounced effect on cognition and behavior and can actually make people quite anxious, especially the first time they get it. So we want to make sure that somebody is able to tolerate that type of an experience. And certain elderly people, as you're asking, could be at higher risk for both those cardiovascular type complications and also for being more susceptible to some of the cognitive perceptual impairments. So that is one of the things we're careful about with the elderly. There's some mixed data out there suggesting that elderly may not have as good of a response as younger adults, but I think the data is early in that phase. I'm not sure we can say anything definitively at this point. In terms of gender, there have been some reports suggesting there may be some different efficacy between male and female, although I think the larger studies that have been done on this over the past few years aren't really finding a large difference in humans. In rodents, interestingly, it does seem like there's some evidence suggesting that female rats may not have the same type of response as male rats, but in humans, we're not seeming to replicate that finding.
When you were talking about the ideal patient, you said that it's important that the patient carries through with the treatment plan. What is that typical treatment plan like?
So there is no standard treatment at this point, but what most typically is being used by most centers, academic centers and private clinics around the country is starting a few treatments, usually spaced about twice a week for a period of 3-4 weeks, and then after that point, it's a little bit of uncharted territory. Many centers are starting to taper out, trying to decrease the frequency. Other centers will actually stop at that point. We did a rather large survey of the centers in North America that were using this about almost 3 years ago, and it suggested that the average patient, at least at that time, was returning for additional ketamine infusions about once every 3 to 4 weeks. Some a little bit more frequently and some able to space it out a little bit more, but it seems to be the average patient somewhere in that time frame is starting to feel the effects start to wane some.
I've seen articles indicating that some researchers feel that it would be important for emergency rooms to have the ability to administer ketamine to people who are suicidal because it can have such a quick impact in some people who are in such a crisis situation. Do you think we're close to seeing that happen, and would you like to see that happen?
So I think we have to be very careful in how this is used because the evidence is pretty good at this point that the large majority of people that have a very good response to the treatment will lose that response over the next few days or weeks. So again, as I said, this really isn't a curative treatment and somebody can feel better, but the symptoms are going to return for at least a substantial proportion of the patients. So we want to be careful that this isn't just being used and sending people home and then their symptoms are going to return and the next time we may not be so lucky to get them to come to the emergency room. So we have to be very careful how we go about using this. You may know that there's actually several large studies now being done with a similar drug, S-ketamine, which is really the S-anthemer of the racemic, just a portion of the ketamine that we're talking about, the regular ketamine, that is being done. And at least a phase 2 trial has shown real promise in being able to use this in people that are acutely and imminent risk of suicidal behavior.
Can you share some success stories of people who have used ketamine and had some luck with it?
We've been treating people at Yale either through research programs or through our clinical program now since 2006. And at this point, we have scores of patients that have had great successes. And in the best cases are people that have had a series of treatments, meaning usually either 6 to 8 treatments, have a good response, and then can maintain that response for years. And we have some patients who have never needed to return for another treatment. I think more frequently what we see are people that, despite not having adequate responses to multiple antidepressant treatments, including ECT, come to us and have treatments with ketamine, have a very good response, and then do end up on some type of maintenance program. Usually, and I think in our hands almost always, with other types of management, usually management with another type of pharmacotherapy and also involvement with a therapist. So this, I try to make it clear to patients, for the most part, this isn't a miracle drug where you're going to get this and everything is better. It is extremely effective in helping people with their major depressive disorder, but for the most part, it is used in conjunction with other medications and also with regular therapy of some type.
And ketamine is not inexpensive.
So it's a little tricky because the actual drug itself is not very expensive itself, at least racemic ketamine. The actual medication itself is not all that expensive by itself, but delivering it is a much more expensive prospect because, as I said, it is an anesthetic drug and it does carry some real medical risk. So giving a little bit too much of the medication could actually put you into an anesthetic state. So you do need some level of medical expertise and specialty to deliver the treatment, especially at the doses that have been proven to be effective in controlled trials. Also, there's enough concern for the effects on cognition and perception and also the real risk to society for substance abuse if this is provided too freely and it's provided to patients to take home, that it really does require very close monitoring from all levels. So it's really the cost of the care that is in part the reason why, the ability to provide ketamine treatment is fairly expensive. Potential risk, both due to the cardiovascular and some of the other risk, the potential risk to cognition, perception, and the potential substance use, that those three factors really would lead people to need to get this treatment with their healthcare provider. I can't say in the future if we have 10 more years of data with tens of thousands of people and we see that this risk is really not what we're afraid it could be, things could change. But I think at this point, it's quite prudent to be careful how we initially launch this.
Do any insurance companies cover ketamine, or is it always something that's out of pocket?
I believe that some insurance companies, in fact, I know some insurance companies will cover this, but more on a case-by-case basis. So it is not widely available for coverage, but some insurance companies do provide coverage under case-by-case consideration. That is very difficult to develop a treatment like that because you can spend more time on the phone discussing the case than ever treating the patient. But in some of the larger areas, especially with patients with severe treatment-resistant, that has been the case, treatment-resistant depression, that has been the case.
Well, you've touched on this a little bit, but the fact that ketamine has been a recreational drug, I'm wondering if you could tell us more about the differences between what is being used in the street and what's being used in ketamine clinics.
So the actual drug itself is not necessarily any different. A lot of times what's being used on the street is actually stolen from pharmacies or in some way obtained off the black market. So the actual drug itself is not necessarily different. The way it's being used is quite variable on the street. As I said, the majority of clinicians that are providing this treatment is IV, but ketamine can be taken by many different routes, including intranasal, actually just drinking it orally. So, on the street, people take it many different ways. I think the major difference is when ketamine is being used on an infrequent basis. So there was a study that I was part of several years ago along with other groups, actually sponsored by Janssen Pharmaceuticals, that showed that treatment 3 times a week didn't seem any better than treating twice a week. So, at least from that study, there was no benefit of increasing the frequency beyond that when initially starting. And then other studies suggesting that you can really taper this out and you don't need to be treating too frequently. In fact, my clinical experience when I've seen people that have actually had some troubles with the drug is when it has been used more frequently than once a week.
If people are interested in learning about ketamine and seeing if they might be a candidate for it or if there's a clinic in their area, do you have any recommendations for where they go?
Well, one of the things that I always recommend is that people consider looking on clinicaltrials.gov. It's actually a listing of all the clinical trials throughout the U.S. and now throughout the world that is using this, and you can actually use this webpage. It's done by the NIH and National Library of Congress to actually learn where these clinical trials are being done. As I said, right now, there's still so much we have to learn about it, and if it is possible to receive this treatment as part of a clinical trial, I still think that is by far the best way to pursue the treatment. So that would be my first suggestion.
And what words to the wise would you have for someone who hears this and is suffering from depression or has a loved one suffering from depression and has seen the headlines about the promise that ketamine and esketamine may hold? What words would you have to them?
My strongest advice is to be very careful before jumping to some of these more novel treatments. I think it's very wise to really engage and develop a good relationship with a physician. And if you're reaching the point of treatment-resistant depression, I think getting advice from a good psychiatrist is probably the first step. Before moving to a medication like ketamine, you really should try to get as much information, as fair and balanced information as you possibly can get. As I said, the treatment offers an incredible potential and hope for people. And I've seen with my own eyes it really save people's lives and keep them well for years. But it's not a miracle cure, and it's not curative for the average person. So this is not something that you can just take this and your depression is gone. This is part of a whole treatment plan. And I think that's the most important part for people to realize, that you still need to be engaged in an overall comprehensive treatment plan.
And Doctor, our show is called Nobody Told Me. So at the end of the show, we always ask our guests what their Nobody Told Me lesson is. And in your case, you have such a wide variety of experience studying depression. And I'm wondering, what do you wish you had known about depression or mood disorders or ketamine?
When I first started out, I think the limiting thing was I thought that this was an illness that we could find a simple medication for, and we were going to cure this with the simple medication. I think nobody told me just how complex this illness and most of our medical illnesses are, that for most illnesses, it isn't as simple as a simple medication curing things. It really does involve a very comprehensive change in lifestyle and medical treatment plan.
Well, Doctor, we thank you so much for joining us. We really appreciate your information and your expertise.
You're welcome.
Our thanks to Dr. Gerard Sanacora, professor of psychiatry at the Yale School of Medicine and the director of the Yale Depression Research Program. He is an internationally recognized expert in the use of ketamine for depression. I'm Jan Black.
And I'm Laura Owens.
You're listening to Nobody Told Me. Thank you so much for joining us.